Okay, thank you. I'm sharing my screen. Is it visible, everyone?
Yes, ma'am.
Okay, thank you. Then good evening. Okay, can we start? Then first case. Just a minute. Okay, then anyone interested to take this case?
Yes, ma'am.
Yes.
Dr. Soumya.
Yes, please.
Should I start?
Yeah. Please describe this case.
Okay, this is a 60-year-old woman who noticed a sudden decrease in vision a few months ago.
Yes.
So this is a color fundus photograph of the left fundus, showing a normal appearing disc and retinal vasculature. And on the macular area, there is a hyperemic pigmentation. So my differentials could be idiopathic or age-related macular hole, then a pre-retinal bleed or solar retinopathy. So first, I would like to take history of the patient regarding any trauma, any exposure to sun or eclipse, then any systemic medication or steroids. Then we can go for investigations in the form of firstly visual acuity, the color vision of the patient. If the patient complains of metamorphopsia, or even if she doesn't, then we can do an Amsler grid. Then fluorescein angiography to rule out any hypofluorescence because of which could be blocked because of the blood. And finally, optical coherence tomography in case this is a macular hole, to judge it, to stage it, and finally we can treat it accordingly.
Okay, then before that, any clinical test you can do?
Yes, ma'am.
Yeah.
Yes, ma'am. On the slit lamp, we can do a Watsky-Allen test wherein a fundus lens is used, and the patient is asked to tell us if the slit beam which we are projecting, both horizontal and vertical, we would do. If there is any discontinuity in the beam, then that goes in favor of a macular hole. And also there is a similar test, the laser aiming beam test. We can show the patient the laser beam which is used in photocoagulation of about 50 microns diameter, and the patient can actually not see it in the area of macular hole, but if it is projected in the adjoining area of macula, the patient would perceive it.
Dr. Soumya, my question is like, what is the wavelength of this wavelength and color of this aiming beam, and why is solar retinopathy a differential in such a case, in this image?
Sir, wavelength, I'm not sure. Is it a green laser?
So, definitely, if you are telling, you have to tell. Mostly, it is a red laser. The aiming beam is red laser, and it is around 633 nanometer. I'm asking, can this kind of large round lesion be caused by a solar retinopathy?
Sir, it is unlikely because solar retinopathy will mostly cause a pigment mottling kind of appearance, not a big, like this kind of a pigmentation.
Solar retinopathy will not cause pigment mottling. It will cause a subtle central white dot or some discoloration in the center of the fovea. The fovea will be but the central fovea where the images are focused, there you will find some abnormality. And if you do optical coherence tomography, you will find some changes in the ellipsoid zone or the RP.
Okay,
So
okay,
because
sir.
the large image, you have to like tailor your differential according to the image. You can say that this can be a hemorrhage, that is okay, and or macular hole, but it solar retinopathy will not come as a DT in such a large type of lesion,
Yes, sir.
large lesion.
Okay, sir. Mhm.
And need for I think need for examine the other eye for solar retinopathy as well. It is the one
Yes,
eye,
ma'am.
so yeah.
We'll examine the other eye for like a similar picture might be there, and to rule out other causes related to hemorrhage or solar retinopathy.
Okay. Then how will you manage this patient?
Ma'am, depending upon the need of the patient, whether the patient has visual needs which are not being catered by this amount of vision, and depending upon the other eye vision, and the vision as such, we can actually keep the patient under observation if it is not very much uh, uh, mm, depriving the vision. And if the need arises, then the surgical treatment would be a pars plana vitrectomy with ILM peeling, followed by like air fluid exchange and gas tamponade.
Okay. Before that, I think you should mention that you need to do the staging of the macular hole, because
Yes, ma'am.
in the stage one we are not doing the any surgical intervention, and from stage 2 and onward we consider surgical intervention according to patients proper counseling with the treatment options, then we can do that.
Yes, ma'am.
Okay, then what about the prognosis of this condition? What would be the prognosis?
Mm, Ma'am, generally, some of the holes would actually get spontaneously healed, and we would see only an ISOS junction abnormality later in OCT. But like some might get surgically corrected, and there might be recurrence as well. So there are all the possibilities.
Mm-hmm.
Mm.
Actually, prognosis depends on the onset of the, is it the recent onset or the older or the chronic cases, or is the size of the hole. So in
Okay, ma'am.
case of the recent onset and smaller diameter of the hole, the prognosis is really good, and even it could
Yes,
be
ma'am.
the spontaneously resolved. And if it is the like more, if the diameter of size of the macular hole is the more than 400 micron, or it is persisting more than 1 year of
Yes,
duration, then the prognosis could be poor. And
yes, ma'am.
most of the cases after surgical repair of the surgical repair, then anatomical success, it is the from the 80 to 100%, but functionally there is the 65 to 85% of the gaining the vision, good vision, at least 2 to 3 lines of visual acuity gaining.
Yes, ma'am.
So
Okay.
this is the actual prognosis. Okay, thank you.
Okay.
And
Thank you, ma'am.
next case. And anyone interested to take this case?
I can take it,
Okay,
Dr.
sure.
Prabhat.
Yes.
This is a fundus photograph of the right eye showing centered on the disc and macula, showing clear media. Vertical cup disc ratio of 0.7:1. Vessels appear slightly nasalized. And there is some background disturbance.
Yes, you
The
can
vessels,
continue. There is,
yeah,
yeah.
slight nasalization of the vessels, but arterioles appear thinner than normal. And there are multiple bony spicules uh, mid periphery, and the foveal reflex appears dull. So this is I would like to examine the other eye, but given the history, And the clinical presentation, I suspect that this is a case of retinitis pigmentosa. Hello.
Sorry. Yeah. What could be the DD for this patient?
Yes. So first diagnosis most likely retinitis pigmentosa. The other could be any other pigmentary retinopathy or even a spontaneously reattached retinal detachment. Or post panretinal photocoagulation. But given the age and presentation, most likely it would be retinitis pigmentosa.
Okay. Then what could be the other ocular association of retinitis pigmentosa?
Keratoconus posterior subcapsular cataract. Some patients may present with glaucoma.
There could be myopia as well.
Yes, madam. There could be myopia as well.
Myopia, keratoconus. There could be a posterior subcapsular cataract.
Yes, madam.
Then what are the systemic association could be, or any syndrome associated with this one?
Yes, madam. There are quite a few syndromes associated with retinitis pigmentosa. Some of the prominent ones, include Cairns-Sayers disease that may be associated with the heart block, and A beta lipoproteinemia, where there is malabsorption of vitamin, fat-soluble vitamins, vitamins such as A and E, and then in addition, Refsum disease, where there is toxicity because of phytanic acid diets. So these are some of the systemic associations of retinitis pigmentosa.
Okay. Did you mention the Usher syndrome? I didn't hear.
No, madam. I mentioned Cairns-Sayers disease and A beta lipoproteinemia and Refsum disease.
Okay. Then you can add the Usher syndrome as well and Bardet-Biedl syndrome.
Yeah, with deafness. Yes, madam. Yes, madam.
Yes. Okay. Then would you like to do any investigation for this patient?
Yes, madam. I would like to do a visual field test. If a larger visual field modality is available, such as a 120, then that would give us more information in this particular case. I would also like to do OCT to look for macular changes that may include cystoid macular edema or macular atrophy or epiretinal membrane. I would like to do an electroretinogram, which is believed to be confirmatory diagnostic test for this. I would also like to ask for a detailed family history because there is significant inheritance known with retinitis pigmentosa that may be autosomal recessive, autosomal dominant, and or X-linked recessive. And preferably ask for the family members to be evaluated. And I would like to ask the patient, I would like to do an initial genetic counseling for this patient regarding possible disease in his children. And I would like to then refer him to a genetic counselor as well for detailed counseling of the same.
Okay. Then anything else to management?
Madam, I would like to know the vision of this patient.
Like it could be the less than 660.
Okay. I would like to give him the option of low visual aids trial regarding distance and near. And I would also advise him to try and not drive himself around everywhere, particularly at night. And try as much as possible to work in bright backgrounds. And in case there are any macular changes detected, I would like to treat accordingly. So, for example, if there is cystoid macular edema, we may consider a course of oral acetazolamide.
Okay. Then anything to add? Anything?
I'm sorry, madam.
Anything to add? Management?
Whatever systemic association is there, that should be treated accordingly in in collaboration with a physician, or if there is a heart defect such as in Cancer's disease, then maybe a cardiologist also.
Okay, any supplement would you like to recommend?
I don't know, madam.
Okay, you can especially you can prescribe the supplementation of the vitamin A.
Okay, madam.
And yeah, this is for the high doses of the vitamin A, and this is especially, and this should be avoided in case of it is the ABC4 gene, 4A gene involved. Otherwise, this vitamin A is beneficial for this kind of patient, especially
Okay.
RH1 gene is involved is there. And you can also add that this kind of patient, you should just register with the visual impairment registration.
Okay, madam.
And for this social service and well-being of this patient. Okay, then.
Madam, with who do we have to register this patient? I didn't follow that point.
Yeah, this is the sight impairment registration. So if you do that, and the patient will get some social and financial benefit.
Yes, madam.
Yeah.
Basically, visual disability certificate or something
Yes,
like
sir.
that. Yeah.
Yes, sir. Yes, sir.
And for next case.
And even
Thank
in if some RP patient has vision of 6/9 or 6/6, they might have visual field constriction, and most
Yes, sir.
this will allow less than 10-degree visual field in both the eyes as 100% visual or 100% disability. So that
Yes,
is
sir.
specific to this case because they are in narrowed vision, and though they have 6/6, but their visual disability might be very high.
Yes, sir.
Okay.
Yeah, then next case. Okay. You like to take this case?
Dr. Nidhi, are you there? Any retina consultant, can anyone take it? Anyone who is practicing retina?
Hello?
Hello, yes.
Yes.
So I'll take it.
Oh, please.
This is a fundus photograph of the right eye. The media appears to be clear, and the disc also appears to be clear. Along the superior-temporal arcade, whitish yellow lesion is seen. Around 1.5 disc, almost 1 disc diopters in vertical diameter, and there's a surrounding halo to it. Rest of the fundus, there is not anything else that is. I mean, nothing else can be appreciated. This looks like to be a astrocytic hematoma. This looks like to be a hematoma of tuberous sclerosis.
Okay. Then what could be the differential diagnosis for this patient?
Foreign body?
Then could be, but unlikely, I think. And it could be even differential diagnosis. You can take the choroidal melanoma and the choroidal metastasis. And if the patient is in the old age, but there could be a previous retinoblastoma.
Is it an old age? I'm sorry, I didn't see I just saw the picture. I didn't see the age and all that. Okay.
No problem. Yeah. Just if this patient, then what history would you like to take for this patient?
Since now I'm seeing the whole scenario, it's a 60-year-old and a male patient.
Yes, it could be a case of trauma. What history would you like to take?
Ma'am, in case for a history of trauma, they would there would be a clear history of some foreign object going into the eye, or some trauma sustained in the past, or in the near immediate time duration. And there would be but there would be other signs also. This looks like a relatively quieter retina, and just a focal lesion is there.
Okay,
There are
then
no
you were told that
hemorrhages.
there are no history of trauma. Then what other history you will take? You will take?
Any floaters?
No, you told there is this with associated tuberculosis. No, so what can be there in tuberculosis?
For that, seizure, any history of seizures in the past? Any
What
medication for
what is epiloia?
what is?
Epiloia. Do you know of any mnemonic called
No,
epilepsy,
sir.
low IQ, and adenoma sebaceum? Like they have this appearance in the cheek, and there may be the intelligence may be suboptimal, and there may be epilepsy, and also periangular fibroma, like near the nerve there may be fibroma in such cases. And also read about the types of astrocytoma, type 1, type 2, what are those. And also one other differences could be calcification. There is something called sclerochoroidal calcification, which is usually seen in supratemporal, near the supratemporal artery. But this is very typical of like maybe the appearance of the astrocytoma, and also the surrounding part is like the astrocytoma can be two types. Please read about it and also post it in the. Please continue. And this retinocytoma, as Dr. Rahima was saying, there is one kind of like benign kind of retinoblastoma, which is called retinocytoma. They can be detected later.
Yes.
They can be detected later in adulthood also, and they can show some calcification like this. But this feature, or looks like this, is very typical of tuberous sclerosis. And some cases might not have tuberous sclerosis also, and they might have just this isolated. Please come.
Okay, thank you, sir.
Okay, then what investigation would you like to do for this case?
Ma'am, we scan to
Mhm.
rule out any calcification.
Yes.
Then for tuberous sclerosis, the MRI of the brain.
Mhm. Yeah, you can also do the OCT to see any subretinal fluid present or not, or also do the fundus process angiography to see any choroidal neovascularization is there or not in the underlying cases. Okay, then what other systemic sign would you like to look for this patient? Am
I'm
I
sorry, ma'am.
what other systemic features would you like to look for this patient? Like any other systemic signs or anything? Okay, then it could be the what already mentioned, sir, that they could be the adenoma sebaceum, and look for the skin, overall skin, for the ash leaf spots, and also for the shagreen patches. You can look for this thing to just evaluate these cases. Yes.
Okay, ma'am. Thank you.
Okay, then next case. Okay. Anyone would like to?
Can I take the case?
Yes, sure.
This is Dr. Farzana.
Okay.
An 85-year-old woman present with the new distortion and luminous of the vision of her right eye. This is the color fundus photograph of the right eye showing optic disc size shape seems to be normal. There are huge retinal hemorrhage involving the macula and also the inferior part of the retina. There are some also some hyperfluorescent dot presented in the macula. So my diagnosis is this is the case of the this is the case of the vitreous hemorrhage. It also have the retinal hemorrhage. It may be due to the proliferative diabetic retinopathy or due to the CRVO or the hypertensive retinopathy.
Okay, then do you think is there any other sign of diabetic retinopathy?
Yeah, there's a hyperfluorescent dot I'm seeing in front of the macula and also in surrounding the
Doctor, my question is this a fluorescein angiogram? How can you see hyperfluorescent dots here? What is this image?
if the hyperfluorescent dots are the exudates, I will see
No.
as
What is this image? What is the modality of this image?
this is the color contrast photograph.
So color photo in color photo, can you say that?
Oh, yeah, we cannot say the hyperfluorescent.
So please think about it and then talk, because once you tell something wrong, then the examiner can take you the wrong way and it will be difficult.
Yes, yes.
Anyone like to add something here or describe this picture again?
Hello?
Hello.
Ma'am,
Yes.
Ma'am,
can I
Yes.
speak?
hello.
Yeah, please proceed, please. Yeah.
I see a grayish white hyper lesion near the fovea, most likely choroidal neovascular membrane, and bleeding from this hyperreflective membrane causes is the cause for the bleeding. Age-related macular degeneration.
Okay. Any other sign is present there?
The vein are tortuous.
No, I mean just for any prominent sign, like there is the
Drusen's are
Trusen's
Ma'am,
are
Drusen's
bruises are there. Yes, yellow white spots. So white spots is the especially in the macula. Okay, then what is the now? What is your diagnosis?
Choroidal neovascular membrane. Secondary to age-related macular degeneration in the right eye.
Okay. Then what is the types of age-related macular degeneration?
Dry and wet type. In dry type, you will get drusen and geographical atrophy. In wet type, RPA detachment and choroidal neovascular membrane.
RPE, yes, retinal pigment epithelial detachment and choroidal neovascularization. Anything?
Okay.
And there could be retinal pigment epithelial tear.
It can occur secondary to RPA detachment.
Yes. Then what investigation would you like to do for this patient?
OCT to confirm the diagnosis.
Okay.
Fundus fluorescent angiography. Shows a lacy pattern.
Yes. Which pattern you will
Lacy pattern.
Yeah, lacy pattern and another anything.
And it shows leaking in the stage. As the stage advances, leaking will continue. So the staining will be more intensive.
Mhm. And how you can classify on basis of the fundus fluorescence angiogram?
There are two types. So in occult CNVM, we will get margins ill-defined, whereas in typical or classic type, we will get the typical lacy pattern with well-defined borders.
What are the types of occult CNVM on angiography? Dr. Ferial?
Don't know, sir.
Okay, please read about it.
Okay, sir.
So then how will like to manage this patient?
Anti-VEGF injection,
Directly.
ranibizumab, intravitreal.
Okay, then anything else?
Ferial, what is massive
NTP.
hemorrhage?
Yeah. Sorry.
No.
Sorry, sir.
What is massive subretinal hemorrhage? Like, what is the definition of that? Please read about it, and also read what we can do if there is massive, like severe blood under the macula which extends beyond the arcades, and what are the options available for those.
Okay, sir.
Sir, I have a query here, ma'am.
Mhm.
Ma'am, why can't this not be a choroidal melanoma?
You can.
Choroidal melanoma is very rarely associated with subretinal hemorrhage like this. There is typical location in the macula, there is membrane, there is brucin, and the age is typically a very old age patient. There are brucin and there are subretinal hemorrhage surrounding an area like a round area which looks like a membrane, CNV membrane. So all of these refer towards in choroidal neovascular membrane only. If there was melanoma, then it would be like a elevated mass like thing. And usually, though there can be subretinal hemorrhage, but this kind of large subretinal hemorrhage is not seen. This image itself will say that this is CNVM, but definitely there may be some cases in which you might be in doubt. In those cases, you have to do ultrasound, and ultrasound will clinically will diagnose it. What is that? Ultrasound is very important. And what are the features of ultrasound? Features of melanoma?
Sir, button-shaped appearance.
And
So acoustic hollowness.
Acoustic forms.
yes, acoustic hollow is very important. And
Choroidal excavations will be there.
yes, choroidal excavation.
Orbital shadowing.
Basically, there is angle kappa, the anterior surface of the tumor will give high spikes, but the inside of the tumor will give low spikes. It will reduce. So that is very suggestive of this thing. But this kind of picture, along with brucin, melanoma may be a differential diagnosis, but it will be in the last of the list.
Okay, sir.
Because this is not a mushroom-shaped lesion also. This is a subretinal hemorrhage. In old age patients, if there is subretinal hemorrhage in the macula, the first differential would be CNVM due to wet AMD.
Okay, sir.
It can be IPCV also, but like wet AMD or IPCV or similar things, not melanoma.
Okay. Thank you.
Excuse me, I also have a query.
Yes, please, please.
Should wet AMD be the first diagnosis rather than PCV?
Yes, you say
Okay.
AMD, to say that this is specific, there are multiple other things which you need to know. And
Okay.
This PCB is a variant of AMD, and most of the examiners will take it. Will take CNVM secondary to this. The diagnosis in such case would be choroidal neovascular membrane with subretinal hemorrhage in wet AMD. This would be
Okay.
the. And if they say that is it wet AMD or can there be some variant, then you'll have to say, sir, I'll have to know the like ethnicity of the thing, ethnicity of the patient, and I want to see the OCT picture if it and also if ICG and angiogram is available, and that will
Oh.
finally identify what it is. But clinical diagnosis will be wet AMD with subretinal hemorrhage.
Okay.
Sir,
Thank you.
and bruisings are also more in favor of wet ARMD rather than IPCV.
Yes.
Yes.
In IPCV, and also in IPCV the color like is a little orangish or reddish like lesion in the around the CNVM or in the CNVM, and there will be more of sub PED bleed, sub pigment epithelial detachment bleed, or there you can see some orange nodules there, but because brucin are there, so in this case it is better to tell that it is wet AMD only, and it will come in the difference here. And it can be PCB also, but the like primary diagnosis will be wet AMD.
Yes. Okay, then come to the next case. Anyone like to take this case?
May I take this up, ma'am?
Yeah, sure. Please proceed.
Okay. Right. So this is a fundus photograph of the right eye.
Hello,
Color fundus photograph of.
hello. My request is please introduce yourself first, just online, your name, and then answer.
Yeah, I am Anirban. So
Mhm.
this is a color fundus photograph of the right eye. The media appears to be clear. The disc appears to be hazy. The disc appears to be mildly edematous, and there seems to be associated pallor. I'm not able to be clear about it. The resolution is not that great. And there appears to be a cherry red spot at the macula, a circular red spot at the macula surrounded by extensive whitening.
Dr. Oliver, what makes you
Uh,
think that there is disc edema in this case? What is the feature you can see?
I am not able to make out the margins clearly, sir. So that is why, like, I am not very sure whether it is there. The resolution is not very great, but I
Yes,
think that the margins are a bit blurred.
margins, like there can be doubt or controversy regarding that. Please
Okay.
focus on what is there. Like disc edema, if you
Okay.
say that it is there might be a controversy regarding that. I might not agree or somebody might agree. So do not go there.
Okay.
Just focus what the examiner wants to see. The critical feature is what is the feature which the examiner wants you to see. Dr. Anivan?
Okay. So yeah, so this will be this is a there is a cherry red spot at the macula.
Yes, that is what examiner wants to see, wants to tell you,
Okay.
wants you to tell.
Okay.
And what is
Okay.
that most likely cause?
Okay, so it's a 72-year-old gentleman. So this is possibly secondary to central retinal artery obstruction. And my biggest worry in this patient would be the presence of giant cell arteritis. That will be on the top of my list.
Yes, like this is giant cell arteritis should not be in the top of the list because giant cell arteritis is not very common, but you must
Yes.
explore that because that has a chance of involving the other eye, and that might have
Yes.
systemic implications also. So do not say that
Yes.
this is the in the top of my list. CRO mostly in this case, CRO has happened due to some emboli, most likely because we
Alright.
have to go in commonality. Like most commonly, this
Okay.
due to some emboli, cholesterol plaque or calcium, mostly cholesterol or fibrin or calcified plaque. That is the most common cause. But in such a case, say, sir, I definitely want to rule out giant cell arteritis in this case.
Okay. 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 Got it, sir. Got it. I would like to rule out. I would say that it will not be on top of my list, but it will be one of the most important
Yes.
ones on my list.
Yes.
Okay. And yeah, this will the next question would be is regarding the pathogenesis, sir, like regarding the causes.
Yes, how the questions can be, how will you evaluate and how will you treat such a patient?
Okay. Okay. So the evaluation will be divided into a systemic assessment and an ocular assessment. So systemically, it is very important to take a history of whether there is any cardiovascular disease, whether the patient is having any history of hypertension, diabetes, and any prior episodes of transient obscuration of vision, and especially if there is any vasculitis history or sickling, sickle cell history of sickle cell anemia. And for the system, for systemically, like it's all for management purposes, if the patient is a smoker, he has to stop smoking. And GC I have already mentioned, sir. So I need to take a history for jaw claudication and scalp tenderness. Uh, system, other things in the system which will be important for me would be to check the pulse, as the patient may have atrial fibrillation, so that can be picked up from the pulse. And I should auscultate the carotid to check whether the pulse is present or not. And I should get an ECG done, as well as blood tests for ESR and CRP. That will be systemic. And for the ocular management, this patient, since he has presented within just 6 hours, I think. Hello.
Yes.
Did you
Hello.
say echocardiogram or carotid Doppler, Dr. Anirban?
Carotid Doppler would be good, sir.
Yes, you have to say that I'll do carotid Doppler and echocardiography because you need to identify the source of embolus, if any. So definitely do not miss that.
Okay. Okay.
In
Carotid
systemic
Doppler
evaluation.
or echocard. Okay.
Carotid
So this
Doppler
is
and
this.
echocardiogram.
Yes.
And a cardiology
And
evaluation. And a cardiology evaluation.
and a cardiology. Yes, I will involve the my cardiologist colleague for a detailed evaluation. Okay. And for the ocular management, so I would make the patient lie down supine and start ocular massage with a 3-mirror gonio. And I will continue the massage for at least 20 minutes.
By supine position, how do you do the ocular massage?
Supine, yeah, actually, supine position, it will be I like this. That is what the book said, sir. Yeah, you are right. I have done it on the sit lamp usually.
Yes, you have to say what is done, what you have done, not what book
Yes.
writes or what somebody else writes. It is not possible in a supine position because you are put. Why are you putting the this thing? Why? What is the role of the one lens which you are putting?
The role of the lens is that by applying the pressure, if we can dislodge the embolus and
So,
thereby
does
restore
it
the occlusion,
does it help
restore
in
the blood flow.
visualizing something? Does it help in visualization of something, or it is just to put pressure? You
We
can put
visualize the optic disc. It visualizes the optic disc, and for that, like we will see the pulsations of the vessel, sir.
Yes, actually, you have blanch that you can induce arterial pulsation by pressure over the disc. You can increase the pressure and just leave it. So sometimes this
Okay.
what happens is the disc or artery blanches, and once you pull back or once you release the pressure, the retina can become like the transparency can start coming, and also the embolus can go to the periphery. So this happens because there is pressure fluctuation. So please read about how we do ocular massage. It is not done supine as far as I know, because you cannot visualize what you are doing.
Yes, yes. It
It
is
is
not
not
done
possible.
supine, sir. I was going by the
Yes,
book. Yes. Right.
yes, yes. So
Yes.
this is like whenever you are speaking, you have to be very careful. Do not speak anything extra because examiners can catch you there. That will be difficult scenario.
Yes.
Please continue.
Yes. Uh, Other than the ocular massage, other measures can be asking the patient to breathe into a paper bag. And and subsequent to that, we can also go for an anterior chamber paracentesis. And topical anti-glaucoma medications can be also used for the intraocular pressure lowering effects, sir. These are the ones on the top in the management and ocular management, and we can go for thrombolysis also in some cases. Other than this, yeah, we can do the NDAG embolectomy in some cases. You can try that also.
Embolectomy, partial embolectomy, hypervised oxygen and carbogen, etc. They have been tried. Just this YAG breakage of the embolus can have complications. So reserve it to what you do, and if the examiner asks what else, what can be done, then only go into the controversial areas or areas where you do not know how to do, or areas which can harm the patient otherwise.
Yes. Right. So, sir, like, what will be the safest answer to this? Like, I will answer ocular massage and anterior chamber paracentesis, because I have seen these two being done.
Yes.
What
Just that, and then stop, and I'll start on some topical anti-glaucoma, or if the pressure is high, I'll give some oral anti-glaucoma and control and continue with topical anti-glaucoma, and then stop
all
if
right.
examiner wants to know what else can be done and how what are other described things, so you can say those things also.
Okay, got it, sir. Got it.
Just
Thank you.
keep your answer very succinct and focus on the things which you have done or which you have seen being done, and then if the examiners want to go to the depth of these things, or depth of thesis, you can theory, then you can go to the theory also. But just say that I'll definitely, before doing that, you explain the patient about the condition and about the prognosis, and counsel about the patient and the urgency of the treatment. Because if you do not do the things, whatever things are there, the earlier you do is the better. So
All
you
right,
have to also tell this in the thing, because time is the more time you lose, the more irreversible the damage back becomes.
all right, sir.
So another question is, what is the time by which the retinal damage becomes irreversible, and whose study was that?
I'm not sure, sir. I'm not sure. I will read about.
Any other
90 minutes. 90 minutes, sir.
90 minutes.
97 minutes, and the study was done by Swan Singh Harry, one Indian, but I think he recently died. But he had severe many publications on the like vascular supply of nerve and venous and arterial occlusions, and the vascular supply of the choroid. Okay, please continue.
Just for interruption, did you take the history of trauma in these cases?
No, I did not ask, ma'am. I would ask that.
Yeah, because it could be a case of commercial retina, right? It could be a case of
Yes.
trauma. Yeah, so first of all, you need to exclude there's a trauma, there is any history of trauma or not. Then you can think about the central retinal artery occlusion, what you said. Okay. Then another thing, you mentioned that you give the ocular message for how long?
Like for around 20 minutes, ma'am. I'm not. What should be the? I'm not sure about the duration.
It's mentioned there in the book, that is for 3 to 5 minutes. Just 3 to 5 minutes. First of all, the
Yeah.
10 to
No,
15
that is
second.
yes, ma'am.
Yeah, you give the pressure for 10 to 15 seconds, then release it, then repeat it, and
Yes.
continue it for 3 to 5 minutes, not more than that. Actually, this is an ocular emergency. So what we need to do, just a quick history and quick ocular examination. And these all measures are not proven, unfortunately. So what we can do as early as possible, what you mentioned, and that is the most important, we need to just urgent refer to the cardiologist to just rule out this any embolism or any recent just stroke. So that is the most important. Just refer the patient, just quick urgent refer to the cardiologist to rule out the causes of the carotid artery stenosis.
Right.
Dr. Anirban, how can you differentiate?
Another thing, how frequent you follow up Sorry, sir.
Please continue. Please
Follow.
continue.
Yeah.
Hello.
Yeah. How long? How you will follow up this patient? Like you do all these measures, but unfortunately, patient didn't get gain any vision.
Yes.
So then you have
Ma'am.
to look for the patient. Yeah.
Yes, ma'am. I will follow him up monthly for the first 3 months, and I will be very careful to look for neovascularization of the iris on every visit, because it is quite common. Like around 20% of the patients of CRAO can develop this.
Yes. Because you need to more conscious neovascularization in CRAO patient, because it is more early developed earlier than the CRVO patient. So you
Yes,
need
ma'am.
to check this patient every 3 to 4 weeks time to rule out any neovascularization in the iris or in the. Okay, then I
Right.
think time is running out. Okay, we next.
Thank you.
Okay, thank you. Anyone would like to take this patient?
Hello.
Yes. Anyone?
Yeah.
Can I?
Ma'am, hello.
Yes.
Hello, I'm Dr. Ponni, the mechanic.
Yeah,
This is the color fundus photograph of the left eye. Media appears clear and disc appears normal with a Caprice ratio of 0.4. With a mild torsosity of the vessels can be seen, and there is a superficial hemorrhage seen in the superior temporal quadrant with exudates can be seen over towards the macula. Then with there is a mild SRF collections can be seen towards the macula with a supratemporal superficial hemorrhage can be seen. The probable diagnosis is supratemporal BRVO. Other it can be vasculitis, or it can be diabetic retinopathy.
Then
yeah,
just try to just avoid the abbreviation in the exam. You can say the branch retinal vein
superior
occlusions.
Superior temporal branch retinal vein occlusion.
Occlusions, and for DD we can also say the hemiretinal vein occlusions, and you can also mention the diabetic retinopathy, or you can also
hypertensive
hypertensive and ocular ischemic syndrome. Yeah, syndrome.
Yeah.
Okay, then how will you proceed for this patient? What history will take for this patient?
So I will like to ask the detailed history about the smoking history, cardiac history, and hyperlipidemic status of the patient. And then I would like to do a detailed systemic evaluations with the complete blood count, lipid profile, then deep hypertension status, then ECG. ECG and echo, and then lipid profile also, to rule out any causes of the occlusion in this patient, and will collaborate with the cardiologist also for ruling out any embolic episode to form this cause. Then and then other tests like chest X-ray, homocysteine level, note here, this is a old patient, so homocysteine level and thrombophilia screening and the antibody test is unlikely. So if it is an young patient, I will send for that CRP level ESR and antibody test and autoantibody test, and with serology.
Yeah, you mentioned that you will prefer this patient for cardiologist, for especially
Yeah.
for which?
Other systemic evaluation, ma'am, for they rule out the thromboembolic episode. Then ocular side, I will after the complete visual assessment and fundus examination, I will do an OCT to rule out any macular edema, cystoid macular edema, and for that I will do OCT, and later on after the subsiding if there is macular edema, I will treat accordingly. Otherwise, I will observe this, and later on, if the hemorrhages are subsiding, I will do for the fluorescent angiography to know the ischemic areas. And watch for this patient. If there is macular edema and the vision is that is worse than 6/9, I will go for anti-VEGF if it is center involving.
Is it better than 6/9? Sorry, what you mentioned?
Worse. It's worse than 6/9.
Or worse. If it is 6/9 or better, yeah, then if it is 6/9 or better, what you will do for this patient?
We can give if it's center involving, we can give NSIDs, ma'am, and observe.
Yes.
For 6/9 or and monthly evaluation is needed, and for the look for any NVI or NVE for to suspect any neovascularization. If there is in fluorescent angiographies of ischemic areas or NVI or NVE, we can go for PRP after that. Or initial management is with intravitreal injection, ma'am. Then after that, if there is ischemic zones, we can go for the PRP, pan-retinal photocoagulation. Sectoral pan-retinal photocoagulation can be tried here.
Okay, before that, then if there is the macular edema is more than 250 micrometer and the patient vision is worsening, then what the first line treatment for this patient?
So, ma'am, if it is center involving macular edema, we can go for anti-VEGF. So monthly anti-VEGF can be given. That is ranibizumab or Avastin or Elia can be tried. So either three monthly injection and give monthly injection according to the response with OCT. Then after 3 injections, we can according to the response, we can extend the treatment. Then if it is non-center involving, we can do an FFA and focal laser also try. If the macular edema, yeah, ma'am. And if it is not resolving macular edema with anti-VEGF, we can shift to steroids also. Intravitreal steroids can also be tried. And otherwise, focal laser also. Yeah.
Okay, then if there is any contraindication to anti-VEGF, then what you will choose? Like this patient has central macular edema, and the patient has contraindication for prescribing anti-VEGF. Then what will be the first line treatment?
Intravitreal steroids can be given, ma'am. Dexamethasone implant can be tried.
Yes.
Macular laser.
Yeah.
Or micropulse laser can be tried with the
edema, so we can first try the intravitreal.
Okay.
What are the contraindications of anti-VEGF, which Dr. Rahima said? Contraindication. What are the contraindications?
So recent history of a stroke.
Okay. And
sir, I didn't get.
And hypersensitivity to the drug. It is rare, but it can be there if there is hypersensitivity to the drug.
Hypersensitive to drugs.
Yeah, then you cannot.
Okay, sir. Okay, sir.
So pregnancy is also a relative contraindication.
Yes.
Yes.
Okay.
Okay, then we can go for
Okay,
next case. Yep. Moving to
Okay.
okay. Anyone would like to take this patient? Take this case? Anyone? Anyone like to take this case?
Please, someone volunteer, please.
This is Dr. Anjana.
Yes. Yep.
This is a color from this photograph of the left eye, showing a relatively clear media. With these margins are very different, the top is ratio of 0.3. And this is that there is venous dilatation. And I can see dot and blot hemorrhages in all four quadrants of the retina with hard exudates, incercinate pattern in the infratemporal quadrant and around the macular region. So my diagnosis based on this image would be severe non-proliferative diabetic retinopathy.
With you said severe non-proliferative diabetic retinopathy. Anything to add?
With clinically diabetic macular edema.
Or clinically significant macular edema, right? Okay. Then you said is the just severe non-proliferative. Can you please tell me what's the types of diabetic retinopathy? How can you classify?
So the PTDRS classification, non-proliferative. Non-proliferative, we have mild, moderate, severe, and very severe. And non-proliferative diabetic retinopathy, it can be either high risk of proliferative diabetic retinopathy or moderate risk of proliferative diabetic.
Sorry, please. There is some poor connection, I think. Can you please repeat what you said? The non-proliferative diabetic retinopathy, then?
And the proliferative, we have high risk proliferative diabetic retinopathy and advanced diabetic eye disease.
Diabetes eye disease. Then under the subdivision of the non-proliferative diabetic retinopathy, how can you classify?
Mild non-proliferative, very mild, moderate, severe, and very severe non-proliferative. In very mild, there are only microaneurysms present. In mild, there are microaneurysms, exudates, which are present, which are not up to the criteria of moderate. In moderate non-proliferative retinopathy, there are severe retinal hemorrhages in not more than 3 quadrants, and cotton spots may be present, and the venous bleeding is can be present, which is not more than 1 quadrant. And for severe non-proliferative retinopathy, we have the 4-to-1 rule, which is the severe retinal hemorrhages in all 4 quadrants, significant bleeding in at least 2 quadrants, and intraretinal microvascular events is not in 1 quadrant. So very severe non-proliferative diabetic retinopathy is any 2 of the 4-to-1 rule. If it is present, it is very severe NPDR.
This case is very severe NPDR. Okay, then what history would you like to take from this patient?
I would like to take the history of the duration of the diabetes, which would and if the patient has other coexisting systemic conditions like hypertension or any other cardiovascular abnormalities or nephropathy because of diabetes, and then the patient is insulin dependent. And
Is diabetes is controlled or not, right?
yes, yes.
Okay. Then how to proceed for this patient? What you would like to do?
I would like to examine the anterior segment of this eye, and I would like to do an anterior segment and posterior segment examination of the other eye as well. So it would be an asymmetric diabetic retinopathy, and that eye can have any proliferative changes as well. So I'll do a complete anterior and posterior segment examination of the other eye. So systemically, I would measure the blood pressure of the patient, because blood pressure control is also important in these cases. And systemically, I would advise the patient the fasting and postprandial blood sugars and lipid profile, and ocular investigations and HbA1c as well. In ocular investigation, I would like to do an optical coherent tomography to document the macular edema. So this case clinically there is significant macular edema. So my management would be go for intravitreal anti-VEGF agents.
Okay.
So based on those, so again, like monthly injections for 3 months, then treat and extend protocol can be followed.
Monthly injection for 3 months or 6 months?
Based on the response from.
Yeah, after 3 months, we can reassess the patient. And how can you assess the patient on follow-up?
Clinically, I look for signs of expectation of the exudates, and I'll do a repeat an optical coherence tomography to look for the resolution of the macular edema.
Sorry, what you said? Will do.
I'll repeat an OCT to look for the resolution of the macular edema.
Okay, yes. You can also assess the visual acuity as well.
Okay. And yes.
Okay, then what is the other options modalities for this diabetics, severe NPDR?
So the next option would be if the patient is pseudophakic, I would like to go for, and if it is not responding to intravitreal anti-VEGF, I would like to go for intravitreal steroids like either Triumph syndrome or dexamethasone implant. But following which intraocular pressure monitoring should be, a frequent monitoring of intraocular pressure should be done, because there is a risk of IUP. Other option would be grid laser photocoagulation. Using a spot size of. Pardon me?
Yeah, that is, you mean that the pan-retinal photocoagulation?
No, grid laser photocoagulation, macular, yes, macular photocoagulation.
Or scattered laser photocoagulation.
Yes.
Then if like this is the non-proliferative, in case of the like proliferative diabetic retinopathy, what it will be the first line of treatment? What you choose for the anti-VEGF or PRP? What you like to do?
If there is coexisting macular edema, my first line of treatment would be an anti-VEGF followed by PRP.
Okay.
If there is no significant macular edema, then I would straight away go with the scatter with the pan-retinal photocoagulation.
Okay, but recently the DRCR protocol is, according to the research, there is the same, this is the same benefit from the injection of intravitreal anti-VEGF is samely effective than the pan-retinal photocoagulations. So you can choose according to availability as well.
Ma'am, and there is another benefit with giving the intravitreals only for a patient who we would have otherwise treated with
Is there any
photocoagulation.
benefit
That
or
is the loss of peripheral
sorry,
vision.
what was the question?
peripheral vision.
Field constriction will not be there with the anti-VEGF, but again, like we have to consider the financial aspects or as well.
Yeah, also that you should be that discuss with the patient, because both procedure have some benefits and for disadvantage as well. Like also in the anti-VEGF, there are some risk of some severe infection as well and some complications. So you need to explain to the patient, and then you will decide what to do for this patient. Okay. Then the next case, yes. Anyone like to take this case? Anyone?
May I take the case?
Yes, hi. Can I take the case?
Yeah, sure. Yeah,
Hi.
please start.
Yeah, I'm Dr. Nidhi. Hi. Yeah, this is a fundus photograph of right eye, which shows elevation, which is in the superiotemporal area of the fundus, which is also involving the macula. And this seems to be some kind of like a translucent structure which is coming from above. In this patient, I would like to sudden changes of vision in the right eye, 52-year-old woman. So in this patient, I would like to examine the patient in detail, and before that, I would like to take a history of any trauma, and would also like to ask any history of flashes and floaters prior to this condition. Then I would also like to, after the history, I would like to examine this patient in detail, checking the vision. Of course, there'll be a visual field defect, which I can see with this kind of picture. Then I'll check the eye pressure. And apart from that, when I see the patient on slit lamp, I would like to see the retrolentals pigments, which will direct me towards any kind of retinal break is there or no, which would lead me to a diagnosis of maybe a detachment is there. And then after examining the patient in detail, the periphery, I would see if there is a retinal tear, which is leading to a like a bullous kind of a detachment, or if I don't see it as a detachment, I would also keep a differential of some like a solid thing which is coming and which is causing the like this kind of a picture, which could be a like a tumor or a melanoma in this case. So it's only by the examination of the periphery as well as the fundus as such, I'll be able to diagnose this condition.
Okay, then what is your diagnosis?
Seeing this picture, maybe a retinal detachment, which is threatening the macula. But
which type?
Most likely looks like a rhegmatogenous retinal detachment with corrugations of the retina.
Yes, you can say it is the rhegmatogenous retinal detachment with macula of.
Yeah, macula is not detached.
Okay, then how will you proceed this patient and how will you treat this patient?
Okay, so first and foremost, I'll do a thorough dilated fundus examination. Look for what is causing this retinal detachment. If there is a retinal tear, whether it is one tear or many tears, which is causing the detachment, and one has to see whether we are able to see everything in periphery. If it's a clear-cut case of retinal detachment secondary to one or two breaks, we'll see whether it is amenable to buckles. If it is, which is an anterior break, we will go for a scleral buckling. However, if there is like more positions of the break, which may be some posterior breaks, some are anterior, which are not amenable to the encerclage or buckle, we'll go for a vitrectomy. And in this patient, pars plana vitrectomy, and in this patient, we also have to see whether this patient has cataract or no cataract. If there is cataract, which is precluding the thorough examination of the fundus, we may have to combine the surgery with the cataract extraction. We'll also have to see whether this patient needs an oil or a gas, because if it's just a superior retinal break, the patient maybe, he can go for a gas injection and she can position, sorry, and then we can treat the retinal detachment. But if there are inferior breaks, we'll have to go in for a silicone oil, and which can be secondarily removed at a later date once the tamponade has, retina has attached fully. We'll also combine this with an endo laser of all the causative retinal breaks.
Okay, then can you just tell me the steps of pars plana vitrectomy if you choose the pars plana vitrectomy for this patient?
Since it's a bullous detachment, which is most likely in the superotemporal more, there is very high chance that you may end up taking the cannula in the subretinal, suprachoroidal space. So you have to use a longish cannula, and once before switching on the infusion, you have to see the cannula tip. So preferably in these cases, you use a larger 6 mm cannula. And once you've seen the infusion tip, you switch it on, and then you do a three-port pars plana vitrectomy. Most likely these days we are doing a minimal invasive vitrectomy, either 23, 25 or 27 gauge. Complete vitrectomy. Yeah.
Yeah, that is the 3 sclerotomy port.
3 sclerotomies, do the complete vitrectomy, induce the posterior vitreous detachment, clear off all the peripheral vitreous adhesions, complete vitreous-based shaving, identify all the retinal breaks, do an air fluid exchange, do the laser around all the breaks, and then exchange air with silicone oil or air with the gas. And you can just remove the ports as such if it's a small gauge, or you can suture the sclerotomies. And that's it.
And what gas you would like to use in this case?
One can use either SF6 gas, sulfur hexafluoride, or C3F8. The sulfur hexafluoride will last for about 4 to 5 weeks, and it will expand up to 2 times. However, if we are using C3F8 gas, it will expand to up to 4 times, but it will last longish, maybe 6 to 8 weeks. So we have to see what we can use. If we are using a silicone oil, it will remain in the eye till the time we want it to be removed. However, we need a second surgery to remove the oil at a later stage.
Okay, then you need to give some instruction, post-operative instruction, like in prone position.
We have to tell the patient for prone position first, because if it's a superior break, gas will tamponade it because of its surface tension, it will rise up. So according to the tear position, we have to tell the patient to maintain the position. And if it's
not air traveling,
we have to ask, no sudden altitude change, no air traveling. And we have to tell the patient, even if it's a phakic patient also, we have to tell the patient to be prone, otherwise he'll develop a cataract. Prone or like maintain the position according to, so that we have to take care for the eye pressure, because the gas may increase suddenly and it can cause eye pressure to raise. You may end up having arterial occlusions. What else?
Okay. Thank you. Then next case. Okay. You like to take this one?
Ma'am, may I?
Yes.
I'm Dr. Vandana. Here I'm seeing a fundus photo, color fundus photo. Media appears clear. Disc margins are clear, well defined. Cup disc ratio is 0.2, and peripapillary. There are multiple breaks in the choroid and Brooks membrane. They are deeper to the retinal layer. So they are running from the side of the disc, and extending into the periphery of the retina. Sorry, extending into the retina. So
Yeah, we can't see here the box membrane and choroid actually clinically. So here we can say this the gray, just gray like gray white linear lesions which is extending from the choroid. Sorry, optic discs to the periphery.
Yeah, yeah. So these are most probably acquired stakes.
Okay, then sorry.
So after observing these streaks, we should be careful while examining the eye because we should not do scleral indentation in these eyes. And these anterior streaks have a systemic association with a lot of connective tissue disorder like Ehlers-Danlos syndrome, pseudoxanthoma elasticum, Paget's disease, and SLE.
Okay, then your diagnosis is the angioid streak, right?
Yes, ma'am.
Then would you like to see the other eye?
Yeah, I would also like to see the other eye, ma'am. And
okay. Then what would be the differential diagnosis in this case? Or what history would you like to take from him?
Any trauma history of any trauma.
Yes, that's the important. Any history of any trauma and any other important history?
Any myopia is there or not, like refractive error?
Yes. Yeah. Any significant myopia is there or any systemic disease? Yes. So, right. Then how will you proceed for this patient?
I will examine the patient with indirect ophthalmoscopy, both eyes, and I would also like to check the intraocular pressure, and then I would like to do the fundus fluorescent angiography and look for whether any CNVM is there or not.
What to do next? Okay, then in case of there is no visual abnormalities, we can just observe this patient, and if there is the CMV, then we can treat accordingly with anti-VEGF, right?
Yes, ma'am. Yes.
Okay, then. Okay, then next case. Thank you. Okay. Anyone would like to take this case?
Portional, like a portional retinopathy.
Okay, just you can proceed. What is the scenario? A 28 years old woman.
28-year-old woman, blurring vision, 4 days. I'm not too sure. Maybe this is like a portional retinopathy. Generally, these patients will have some kind of trauma, and they will have these bilateral vision. Yeah.
Like to take?
Any history of trauma, very important, because these compression injuries may cause like a lot of embolism and vessel damage, and they will cause these kind of whitish appearance along with hemorrhages both eyes. They may also have pancreatitis, history of pancreatitis, or some vasculitis, or some kind of embolism, not too sure, but yes, fat embolism because of trauma or pancreatitis anyway, I've told. And then sudden bilateral vision loss will be there. And generally, if the primary condition has been taken care of, it should resolve within few weeks. And that's it. So we have to see the primary cause in these cases rather than treating the hemorrhages and whitish appearance of the retina as such.
Yes, that is the like multiple whitish patches over the around the papillary region. So okay, you're right. It could be a case of pustular or pustular-like retinopathy. Then what is the difference between pustular and pustular-like retinopathy?
I think personal retinopathy classically was described in terms of pancreatitis. That's what I remember. I don't know.
Partial, what you said? Please repeat again.
Partial retinopathy is classically with pancreatitis. I'm not sure. And this personal-like can be because of other causes like trauma and vasculitis and embolism. Not too sure.
It's just you say just opposite. Pustular is directly to the trauma.
And
like is in other causes like pancreatitis, embolism, or any other systemic causes, connective tissue disorder. Or it could be, in case of female, it's 28 years. You need to take history about the pregnancy because it could be related with the preeclampsia as well, right? Okay, then this is the okay. This then from history we can, if there is a history of trauma, then we can also take DD. We can think about the not just typical, but we can in DD we can come to the commercial retina and also the hypertensive retinopathy. And if there is any history of systemic disease like any autoimmune disease, SLE, will be there. Okay, then the management wise, then if the visual loss is mild, then we can observe. Or if there's a severe vision loss, especially from the trauma, then we can consider the intravenous steroid high dose situation, or otherwise, if there is the underlying cause, if there is in the known underlying case, we can treat accordingly that causes. Okay. Okay, thank you. It's the posture retinopathy. Then anyone would like to take this case?
I will try.
Yes, sure.
Okay, I'm Dr. Charlene. So these are fundus photos of both the left and the right eye, both showing hypopigmented ring around the fovea. That is slightly granular in pattern with some pigmentary changes temporal to the fovea in the left eye, given a bullseye appearance. The disc appears to be round and the margins clear, and the vessels are of normal caliber. The rest of the retina appears to be healthy. So my diagnosis, in keeping with the history of a 52-year-old lady with a history of SLE with worsening vision, maybe hydroxychloroquine or chloroquine toxicity of the retina secondary to her medication.
Okay, what the clinical signs consistent with?
A clinical signs may be consistent with maculopathy due to toxicity of the hydroxychloroquine.
Yeah, more specifically, we can say it is the bullseye maculopathy, right?
Okay.
Okay, then what history would you like to take? This was mentioned, yeah.
I'd like to take a history of other systemic illnesses like renal disease, hypertension, diabetes, use of medications, and the dosages and duration of which they were placed on it, for any other drugs used or vitamins that may be retinotoxic, smoking, history as well. History of trauma, just to rule out a case of commotion as well. And then I would like to do an examination with respect to the visual acuity, aided and unaided, the intraocular pressure and refraction, I would do a full slit lamp examination, examining the anterior segments as well, and do an OCT to look for any photoreceptor damage as a result of therapy, where you will see a flying saucer pattern just beneath the fovea, a clear area denoting photoreceptor damage.
Okay,
I'll
and how
also
will
look. Mhm.
how will you manage this patient?
I would counsel the patient on a possible prognosis, considering the fact that she already has worsening of vision, and educate her on the fact that it's irreversible. Once it's due to the medication and photoreceptor damage has occurred, I would work in tandem with her rheumatologist to place her on other medications that would spare the high dose of hydroxychloroquine and avoid other retinotoxic medications. I would also advise on low vision aids depending on the vision that she has, and join her to other social support groups, blind registration, and advice on driving alternatives as
Okay,
well.
then what could be the prognosis of this patient? The prognosis?
Her prognosis could be poor since it's irreversible damage that may have been done.
Is there any chance of reversible vision reversible?
Not that I'm aware, unless she has coexisting disease results in macular edema that we might have found that could be reducible by intravitreal anti-VEGF agents, possibly.
For what?
I'm not sure.
Yeah, no, that is there is actually is that unfortunately there is no chance of reversal of vision because it is causes the irreversible vision loss, especially with hydroxychloroquine. So if the patient is the systemic lupus erythematosus, so most likely she is taking the hydroxychloroquine for a long time, and that causes the permanent damage with the retinal layers. So is for this patient, I will the best to the counseling of the patient. Yes, the patient counseling and inform the rheumatologist to change the medication if possible, the alternative medication, and other measures of the dimness of the vision like low vision aid and anything else. Okay, then what would be the hydroxychloroquine? That is the any particular doses to cause this kind of maculopathy, or any time or any duration?
A duration of over 5 years of 200 milligrams per day.
Yeah, just a 5 milligram per kg body weight per day. Yes, for is more than the 5 years, then there could be there is this chance of macular damage. And for this, the patient should be screening. The annual screening should be done for this kind of patient who is taking hydroxychloroquine for a long time. Okay, then thank you. Then the next case, I think, is the last case for today. It's the long time. It's already more than 1.5 hours. Okay, anyone would like to just a quick review of this case? Anyone?
I can try.
Yeah, sure.
Okay, Dr. Prabhat here. This is the fundus photograph of right and left eye. Newborn baby, as mentioned. The view is hazy. Disc is seen. Vessels are arising from the center of the disc. In the mid periphery, however, there are pre-retinal hemorrhages, and peripheral retina does not show the proper vascular pattern, the significant avascular areas in both eyes, with abnormal vessels at the junction of vascular and avascular retina. This is looks like a zone 2 retinopathy of prematurity. I am unable to comment on the stage since the photographs are not very clear. And there is also significant vascular tortuosity that suggests that there may be a component of plus disease.
Yes. So we can see here, this is like looks like the fibrovascular just extraretinal proliferation. So it is the 2D picture. In that case, and there is some like ridge structure is there. Yeah.
Okay.
Ridge. So we can say as this is
Stage
the
2.
extraretinal proliferation is stage 3 because it's not there is the neovascularization is there.
Okay.
And zone wise, it could be 1 or could be 2. Is just the marginal because if you just draw an imaginary circle from the here, twice from there, it could be here. So some is sorry. Okay, and somehow it's in the grade in the zone 1, we can say.
Okay.
So
Zone 1 to 2.
Yeah, 1 to 2, or yeah, 1 to 2. Stage 3 is 1 to 2, and with plus disease. Right. Then, what history would you like to take from this baby's parents?
So we already have the gestational age and birth weight. I would like to take history of immediate post-birth oxygen therapy, number of days spent in the ICU, and incubation, neonatal jaundice, neonatal fever or sepsis or any such comorbidities.
Yes. Then how will proceed this patient for this patient?
How many days after the birth have we seen the baby, madam?
Usually, the first screening should be in the 4 to 6 weeks after birth, and or the 32 weeks of 1 weeks of gestation. Which one is the later? Yeah.
Okay. So this is a fairly aggressive form of the disease. So I would like to intervene early with. I would prefer a trial of intravitreal anti-VEGF injection, half the dose of the standard adult dose in both eyes, and then follow up at 1 day post-operative and then 1 week, and then every week to look for gradual reduction in the avascular area and improvement in the overall retinal status. And if the plus disease persists or if there's no improvement in the staging, then we may also consider photocoagulation to the avascular retina.
Yes. And any other options rather than photocoagulations?
Madam, anti-VEGF I have mentioned.
Yeah, that we also mentioned, and then we can also try for the cryo. According to the cryo ROP trial, we can use cryo instead of laser.
Yes,
okay,
madam.
then. Okay.
Madam, should we still mention cryo, though it is not being done anymore commonly by retina surgeons?
No, it's the options. So if you have the facilities, you can use. We are discussing about the options, yeah.
Okay, madam. Okay.
Okay, then thank you, everyone.
Ma'am, what is the dose for bevacizumab for ROP?
I think it's the 0.1 ml as per I just
Ma'am,
remember.
may I answer that? Ma'am, may I answer
Sorry.
that?
Yeah, sure.
Ma'am,
I just put this one in this
it
time.
is
Yeah.
0.625 milligram. It is half
Yeah.
of the adult dose, so it's 6 milligram. And it is just one unit that is given at 1.5 mm from the limbus.
Yes. Okay. Thank you. Yeah. It's the
Thank
Only
you.
difference,
one
the
unit
half
or
of the
even
adult
less
dose.
will
Yeah.
Thank you.
Sorry.
Thank
Anything?
you, madam. Thank you. Thank you.
Okay. Thank you.
Thank
Then
you,
we
madam.
can
Thank you, madam,
get
so
at
much.
the end of the session. Okay. Thank you so
Thank you,
much.
madam.
Thank you, ma'am.
Thank you, ma'am.